Was when I was doing my PhD at the Institute of Psychiatry that I was introduced to anthropology, and at that time they were combining anthropology and epidemiology as part of their doctoral studies. So many of my views on mental illness changed after that, and I have looked at mental illness very differently from during my training days. So the plan of the talk is that I'm going to discuss the evolution of psychiatric classification, the cultural understanding of psychiatric diagnosis, the value judgments we make when we make diagnosis, and the practical approach to management. Now, in the 1950s and 60s, there was extensive debate within the psychiatric fraternity whether depression was a disease or was it a reaction to stress. So you had this categorization: endogenous, exogenous, physiological, psychological. Melancholic versus neurotic depression. Was this distinction one of severity or quality? At that time, there were a lot of psychoanalytical theories which actually were unprovable and untestable, which muddied the waters. And there was this famous experiment by Rosenhan. He asked volunteers to go and present to various mental hospitals in the US, claiming to hear some thuds or noises. And they were all diagnosed to have psychosis and admitted to mental hospitals. And despite the fact that they were behaving normally in the hospitals and they were taking detailed notes as to how they were being treated, the psychiatrists continued to treat them as mentally ill. And then finally they were discharged, and some of the psychiatrists even said that they will pick up such fakes if they were sent later. But despite the fact that no fake patients were sent by this author later, there were still some people incarcerated saying they were part of this setup. So this was a huge embarrassment to psychiatric fraternity. And there was this famous US-UK diagnostic project where it published that the American psychiatrists had a very broad definitions for schizophrenia, while UK psychiatrists had very narrow definitions. So the problem was one of interpretation. And in the absence of etiological, pathological diagnosis, and pathognomonic symptoms, the focus had to be symptom clusters. And it was at the University of St. Louis where a group of American psychiatrists decided to come up with operationalized criteria. It was the Finer's criteria published in 1972, day-to-day experiences, which they made into symptom counts, objective symptom counts. They came up with thresholds. They decided that interpretation was only when stress, coping, context, supports, and culture were interpreted. And they decided no more interpretation by psychiatrists. You just count the symptoms and come up with a diagnosis. Obviously, with this approach, inter-rater reliability improved dramatically, and it also sidestepped the disease-illness controversy. So, major depressive episode, which they came up with, became the gold standard. And they decided that they needed to subclassify various depression, various psychiatric syndromes, so that ultimately you would find some biological etiology and biological solutions. So we had Spitzer's research diagnostic criteria follow, and then the DSM-3 in 1980. The DSM-3 was embraced by the pharmaceutical industry as it gave them a homogeneous group to study their randomized new molecules and conduct randomized trials. Now, what was the fallout? The fallout was that we now have a symptom checklist. It is equated with biological disease. There's a subordination of stress-related problems like adjustment disorder and chronic depression. We discount all stress, coping, context, supports, and culture. Despite the fact that nearly all our diagnoses, except maybe dementia and delirium and organic conditions, they lack predictive and biological validity. Antidepressants have been the solution to all forms of distress. We now disregard spontaneous remission and placebo response and claim it and give credit to antidepressant. Psychotherapy is often praised but seldom practiced. Now, what has been the impact? It blurred the disease-illness divide. It medicalized all distress. Now we have multiple categories with the similar treatments, antidepressants. The pharma industry started slightly modifying molecules and greening their patents so that you could extend their profit-making ability. There has been a standardization of the interview and the diagnostic process at the cost of humane interviewing. The art of history taking has been reduced to symptom checklists. And as Nancy Andreasen recounted, she was part of the DSM-3 process, that the best available evidence has now become gospel truth. Now the question is, how did DSM become so popular and famous across the world? And it has everything to do with the capitalistic society and the world we live in. Structural problems like income inequality, poverty, patriarchy, caste, sexual, linguistic, and religious discrimination, social exclusion, political oppression, forced migration, and ethnic cleansing have all been removed as contexts don't matter anymore. Medicine and psychiatry are very much firmly part of capitalism, and we offer technical fixes to structural problems through medication, making more profit for many industries linked with us and worsening the structures of inequity. We conflate difference with biological sameness. We conflate biology with poverty, patriarchy, and caste. We have private solutions to public health problems. And this whole movement, the diagnostic and classificatory movement of the American Psychiatric Association, has been exported around the globe and has radically altered cultures and the undergird psychiatric formulations. And I must admit that all of us are complicit. We speak the language of mental health, but we undermine many people's mental health. The New York Times called the DSM classification America's greatest export ahead of its arms industry. It's become part of the labels and treatments have become part of popular culture, used by people who seek mental health services. They offer distinct and very diverse niches to the different stakeholders, diseases to doctors, reimbursement to the insurance and hospital industries, profit for pharma, and deflection of responsibility for governments. They have opened up new diagnostic spaces like PTSD and ADHD. Which have moved from very restrictive contexts to whole new populations. There's been an expansion and a loosening of definitions, and many of these are not value neutral despite their claim, nor are they above specific interests. Now, the hope was that reliable diagnostic criteria and subclassification would allow us to come up with valid predictive and biological categories. But 50 years later, this hasn't happened. Now, diseases are not absolutes. They're just indicators of current understanding. Diagnoses are not absolute. They're indicators of current understanding. They help in communication. They help administrators come up with numbers. They aid in reimbursement. They provide pharma with homogeneous populations to test their drugs on. Psychiatric treatment currently is symptomatic rather than disorder specific. It has also been formalized as trans-diagnostic interventions. It also helps people in distress. Now, if you look at psychiatric diagnosis, these are essentially symptom clusters, which started as Euro-American idioms of distress. They were subdivided to achieve homogeneity in terms of etiology and pathology, but yet we do not have any such answers, and they remain homogeneous, they remain heterogeneous symptom clusters. Diagnosis in psychiatry represents distress, illness, disease, which is now called disorder. We have symptom disorders and syndrome disorders, all of which have a disease halo. Now, the second part of my talk is the cultural understanding of psychiatric labels. Now, what are idioms of distress? These are ways of expressing distress which are shared ways of experiencing and talking about our concerns. Idioms of distress initially describe distress in non-Western cultures, but recent understandings have argued that our cultural matrix shapes our experiences of an expression of distress, that all diagnostic and classificatory systems are not independent of the cultures they were born in. So what are the characteristics of idioms? They are shaped by individuals, families, society, and the medical profession. Symptoms have a metaphoricity, that is, they convey a variety of distress. They are performative, they are a form of social action that affects change. Idioms are polysemous, they have multiple meanings, multiple pragmatic implications, they are prone to improvisation, they can be adapted to new and changing contexts. They are contradictory, they are transactional in nature, and are starting points for negotiation between patients and their healers. Now, explanatory models of illness, a term introduced by Kleinman in the 70s, are frameworks, explanations, meanings, and mechanisms to explain illness, symptoms, causation, and their treatment. And we have actually shown that people hold multiple and contradictory explanatory models of illness. They would believe that their symptoms are due to black magic while simultaneously coming to hospital and demanding medication. People seek in sequence and concurrently they seek help from diverse sources of cure and healing. Now, these new idioms, psychiatric idioms of distress, of depression, anxiety, panic, etc., are easily accepted by cultures and populations, and they are simultaneously held alongside folk beliefs and folk idioms. Now, looking at psychiatric terminology, they reflect Euro-American idioms of distress. They are the new currency in mental health. They are recognized around the globe. They coexist with local and regional idioms. They serve as additional options for negotiating access to care. They are useful, use medical nomenclature to highlight their distress, for seeking diagnostic tests, for shopping for health intervention, and for supporting medicine-taking behaviors. Now, psychiatric labels have evolved far beyond their original meaning. People who are unable to cope with life's demands flood mental health facilities, presents with psychiatric idioms readily recognized by the symptoms. These new idioms coexist with old idioms of distress, cultural ways of expressing concerns. They are encouraged by diverse stakeholders and used across cultures. Now, we as healthcare providers recognize these idioms. We convert them to disorder labels. We offer new meaning, attribution, conceptualization, and reframe distress, provide personal, social, economic support in addition to medication. Now, if we look at the medicalization of distress cycle, what started as Euro-American distress led to Euro-American clusters of symptoms. We came up with psychiatric diagnosis, a disease explanatory model, and psychotropic medication. Psychiatric diagnosis then feeds in, we educate patients about the new disease model of distress, a new disease idiom. We prescribe medication and suggest that these are the cures for their distress. And these patients learn, understand, and incorporate these new psychiatric models into their presentation. And in addition to local idioms of distress, they also seek help using psychiatrists' new explanatory models of illness. And this is the medicalization of distress cycle. Now, what are the drivers of medicalization? The biomedical paradigm is certainly one, the pharmaceutical industry, insurance and reimbursement policies, and now in our fast-paced society, there's a cultural expectation in the population for quick and technical fixes. I remember in the villages around Vellore, we have doctors going around, they're called fever doctors, and they essentially give steroid injections to bring down fevers of poor people who need daily wages to work. And if you give a steroid injection, the viral fever will come down and the people can get to work. So there is a cultural expectation from our patients as well for quick fixes. So it is in our professional interest to push for medicalization. Now, what are the consequences of medicalization? There are positive consequences. It validates people's suffering. It reduces moral stigma of illness. It can advance research into various mental health states. But the negative consequences are that it pathologizes normal human experiences. It undermines resilience. It neglects social and determinants of mental health. There is overdiagnosis, and there is excessive reliance on medication. Now, coming to this topic of value judgments in psychiatric diagnosis. Now, psychiatry says that all our diagnoses are evidence-based, but philosophers and ethicists argue that all our diagnoses have value judgments. We have shifted from the moral issues and freedom of choice to medical and scientific and causal determinism for insanity, for sexuality, for substance use, and for mental disorders. So we have shifted. So it was a sin or moral weakness in the past, and now it is a medical and scientific problem as far as many of these conditions are concerned. In addition, every diagnosis states that we have to evaluate dysfunction, disability, impairment, and distress, which is required for diagnosis, and that involves a clinical judgment. Equating mental illness with physical illness is also a value judgment which we don't usually acknowledge. Now, value judgments, there are three kinds. There are value investments and commitments. So relief of suffering is an ethical imperative which is acknowledged by the framers of DSM. The acquisition of knowledge is an epistemological imperative. There are value consequences of stigmatization and discrimination through diagnosis. There is harm due to inappropriate medicine prescriptions. There are some value entailments. A neurobiological worldview is reductionistic. We reify criteria, diagnosis, and classification, making abstract concept into concrete issues. There's a commercialization of mental health care. Now, DSM-5 does not acknowledge the role of value judgment, of stigmatization and discrimination, of overdiagnosis, of excessive prescribing. There has been a diagnostic creep which is benefiting pharma. There's a misplaced concreteness to abstract ideas. There's a conflict of interest between biological, when we talk of biological reductionism or when we talk of relief of suffering. And there's a definite neglect of social causes, structural causes, and social determinants of mental health. DSM does concede indirectly that the aim of relieving distress and that DSM aids in this clinical practice. The focus on benefits of early intervention, like in attenuated psychosis syndrome, means that they do indirectly acknowledge that there are some value judgments. But many ethicists have argued that psychiatry needs to openly acknowledge that its diagnosis and classificatory systems are not only evidence and fact, but also involve value judgments. Now the question is, here we have the psychiatric system of diagnosis and classification, which is supposedly evidence-based. You have people who have, for centuries, have their own idioms of expressing their distress, who quickly incorporate these modern and psychiatric explanatory models to seek help and care for their distress. Ethicists argue that we are making value judgments all the time, even while we are making symptom checklist based psychiatric diagnosis. So the question I often ask myself is, how do we then approach our patients so that we can come up with some kind of coherent approach to them without medicalizing distress and yet helping them cope? Now, if you look at the way medical diagnosis works, people who have studied it have come up with this idea that novices use an analytical deductive strategy. They use a feature by feature match. They use it sequentially, and then they come up with the diagnosis. Essentially, they use a checklist. But experts usually, they pick up patterns, recognize them. It's an unconscious, holistic, exemplar process. It's an exemplar match. So the clinical challenge for all of us is to recognize the pattern. Is it a normal reaction to an abnormal situation? Is it an abnormal reaction to stress? Is it a pattern of chronic stress coping with fluctuations? Or is it severe depression without precipitating stress in well-adjusted individuals? And once you've picked out one of these 4 patterns for anxiety and depression, then you can look at the checklist to see whether they satisfy the criteria, rather than looking at the checklist and trying to fit them in to the pattern. So, normal reaction to abnormal situation comes up in the Z codes which ICD has. We psychiatrists tend not to use them, but I think we should use them. For example, I often feel that when women come with domestic violence and alcohol problem, alcohol drinking in spouses, by saying that the person is depressed and there's a biological problem in her brain, that is adding insult to injury. So it is better to stick with the Z code, saying that either there are social determinants of education, employment, housing, poverty as the problem, or social, family, and personal circumstances of marital discord, domestic violence, or academic problems. So I kind of feel that when people present to us in distress, and if you feel that their distress is normal based on very significant problems they face in their lives, it is better not to give them a medical label and actually highlight for the diagnosis the ICD-10 Z code, which allows you to do that. But somehow in our training we don't use Z codes very often. But I think we should, because what we are telling the person is you are normal, but you are in a difficult situation, and this reaction is legitimate. You're allowed to grieve or be upset or cope with difficulty. The next is the adjustment disorder. Here we are saying that there is severe stress and maybe this is an overreaction. That would be adjustment disorder. Now, persistent depressive disorder or chronic depression is chronic depression due to poor coping, fluctuation, with every small and multiple stressors they face. Melancholia is the rare diagnosis of severe depression, usually late onset, less than 6 months, with no stressors. Now here is a list. So basically Z code for a normal reaction to circumstances. is brief. Adjustment disorder is abnormal reaction to severe stress. It's also brief and self-limiting. Chronic depression is poor maladaptive responses to multiple chronic stressors, usually young onset and chronic. Melancholia is rare. It's usually in the 5th decade of life, unless it's first episode bipolar, when it can be younger. It's often brief, and that's where we should then argue for disease status. But for all the others, we don't have to come up with disease explanations. Now, if you look at DSM-3, I'm not very sure, DSM-5, I'm not very sure if people have read the small print, but what in DSM-4, what they said was, if you satisfy MDD diagnosis, then you cannot be diagnosed as dysthymia. But then they realized there are lots of people with chronic depression, and they have clustered with this new label, persistent depressive disorder. They have brought together dysthymia, which is non-MDD chronic depression, double depression, which is MDD on dysthymia, chronic MDD, intermittent recurrent MDD with or without recovery. Chronic MDD is often, chronic persistent depressive disorder is often associated with comorbid anxiety, substance use, personality disorders, poor coping and supports, and childhood adversity. It is more commonly seen among women, among the poor, and those affected with social determinants of mental health. Now, when you look at this anxiety-depression overlap, this is a traditional psychiatric dichotomy. It is, it's etched in stone, and I just want to mention a few issues. I was presenting some paper on statistical modeling on depression and anxiety data for the DSM-5 conference in London on separating on depression and anxiety. And our data actually argued that it's very difficult to separate. I remember asking, actually it was Professor Sir David Goldberg of the GHQ 12 fame, who asked me, Jacob, can you do this for us? I had done it for my PhD, and he knew me because I was in the same corridor as him at the institute. And I did it on a cohort of 15,000 patients from across the globe. So I asked him at the start, David, can you tell me what are symptoms of depression and what are symptoms of anxiety? Where does worry, fatigue, lack of concentration, sleep disturbance, where do these symptoms fall? And actually they fall on both sides. They're part of anxiety, they're part of depression. And so that was one issue. And if you looked at the field trials of DSM-3, I remember studying this because I had just joined psychiatry. What happened was everybody who was diagnosed to have generalized anxiety disorder also was diagnosed to have a major depression. That is because the symptoms are very similar, they're related, they coexist, and these symptoms often overlap. So the trick DSM-3 did was to put a 6-month criteria for generalized anxiety and a 2-week criteria for major depression so that you did not have this overlap. So that was actually a neat trick which DSM-3 did. At the conference, at the end of the conference, the chair of the conference, David Goldberg and Kenneth Kendler, they came up with this idea that the framers of DSM-3 without evidence separated anxiety and depression. Now that we have so much evidence that they're very related, let us at least put them in an overarching category. We can't merge them because that would be impossible because they are specialist anxiety clinics and specialist depressive clinics. So let's actually put them in an overarching category. That was the recommendation of the conference. But of course, the board in charge of DSM-5 completely rejected it because this dichotomy is such a pillar of psychiatric thought that touching it would be disastrous for psychiatry. So they decided that they leave it as such. So very often you have mixed and subsyndromal presentations. We have to ask ourselves, is it just symptoms? Is it just day-to-day phenomena? I'm anxious about an exam, which is normal, to full-blown panic with spontaneous remission. So do you have symptoms, subsyndrome, full syndrome? Can we identify stressors and context? So if it's a Z code for depression and anxiety, they need social support, psychosocial support, and if they're not sleeping, maybe low-dose amitriptyline. I now work in a secondary hospital, CMC's branch in a place called Chittoor, and 10 milligrams amitriptyline is the most popular tablet. It's not used as an antidepressant, it's used just to give these people who are not coping with life a good night's sleep, so that they're not tossing and turning, and they have the ability to cope the next day. Adjustment disorders, similar, psychosocial support with some symptomatic help for sleep. If it's persistent depressive disorder or generalized anxiety, then they may need antidepressant plus CBT with a change in philosophy, attitude, and lifestyle. If it's melancholia or specific anxiety disorder, it's antidepressant plus CBT. So what are the implications for practice? We have to examine the longitudinal course. We need to acknowledge the context, distinguish the pattern, recognize stress, ascertain safety risks, identify supports, manage poor coping, rule out medical causes. We need to, if we feel that this is a Z code category of a normal reaction to an abnormal stress or overreaction to severe stress, then we need to normalize, we have to normalize distress and build resilience to say, yes, you're normal, but you're going through a very difficult time. Yes, we will support you, but you don't have any biochemical problems in your brain. We have to give them meaning and explanatory models which will empower them. We have to recruit community and family supports, and we have to come up with shared decision making. So we need comprehensive management where you combine tablets with counseling. We need to clarify the role of medication. Often when I prescribe, I have nothing against antidepressants. I feel definitely we need to give them, especially if they're not sleeping. I often say this, if it's stress-related problems, I often say this tablet will help you, but it's not going to solve your husband's alcohol problem. This tablet will help you, but you need to sort out your academics and studies. This tablet will help you, but you need to look for a new job. We need to discuss how they cope with stress. I often, to every one of my patients, I talk to whether they go to the temples or mosque, whether they do puja every day, whether they have physical exercise, whether they at least go for a walk, pranayama or deep breathing, Shavasana or Jacobson's progressive muscle relaxation and meditation. Every one of my patients, whichever presentation they have, I always discuss this with them. For chronic problems, we have to talk about a change in philosophy, attitude, and lifestyle. We have to consider social interventions. In chronic depression and anxiety, there has to be some hint at personal responsibility to change their approach to life. And we need to come up with the biopsychosocial approach. Biopsychosocial approaches are often praised but seldom practiced. Biomedical approaches tend to trump biopsychosocial approach. So what is the status of psychiatry? We still have in our diagnostic categories a cluster of symptoms. There are fuzzy boundaries, high comorbidity. They are reliable categories, but they're not valid. Actually, when I looked at DSM-3 field trials for major depression, which is, the standard psychiatric diagnosis, the kappa for inter-rater reliability was only between 0.2 and 0.4, which is completely unacceptable. But because psychiatry has won the inter-rater reliability debates, nobody is looking at the fine print to see that our diagnoses are still not really reliable. We still await biological and predictive validity for our categories. Our categories convey a variety of distress, have multiple meanings and practical implications. They are essentially symptomatic and trans-diagnostic treatments. Good medical practice means that we understand context, stress, coping, and supports. we need to identify the presenting pattern, and maybe we have to make some value judgment on that pattern. We need to come up with holistic approaches to cure and healing. So in conclusion, the best available evidence, which is DSM-5 and ICD-11, should not become gospel truths. We should value judgments are part of the diagnostic process, and good psychiatric practice, good mental health practice demands common sense and clinical judgment. Psychiatry awaits its scientific revolution and paradigm shift. We are still at symptom counts and symptomatic treatments. Thank you.
Thank you very much, Dr. Jacob. It's a very enlightening lecture. I have been a proponent of medical model of mental illness for a very, very long time and will continue to be so. But the way categorical diagnosis has evolved over years scares me. Dimensional diagnosis has gone into history. When I was a postgraduate student in late 60s, anxiety, depression with hysterical overlay was considered a normal diagnosis. Today it is laughable. And yet the fact remains that what you mentioned, a woman who is abused at home will come to you with anxiety, depression and use her symptoms to draw some sympathy and attention. So there are people who suffer from anxiety, depression with hysterical overlay. Today my patients ask me, is it anxiety or is it depression, doctor? Nobody has been clearly stating whether it is anxiety or depression. All the doctors say that take this and you will be all right. Well, I am feeling better, but I want to know whether it is anxiety or depression. Isn't it important? So we have gone to that level. And, well, medicalizing everything is dangerous, because while we need a diagnosis, absence of disease is not health. And therefore, when you talk about mental health, the factors beyond medical, social, cultural, economic, all those come into picture, and we are often missing out on them. So that's very important, and it was a wonderful, enlightening lecture. You clarified it beautifully. Thank you so much.
It was really a joy listening to this, because it provoked so much thought, sir. We've been reading of the psychiatrization that comes from the West. It's come to India also. Actually, it's not just psychiatrization, because even now hypertensive criteria, changing in such a way that all medical illness is slowly going to come under this rubric. So I have always thought of this like a type 1, type 2 error. So, the false positives of type 1 are your overdiagnosis, overtreatment. And then for years in India, we've had underdiagnosis, undertreatment, like sir said, sometimes rubbishing of, hum bhi ye sab deal kiya hai, you don't have to make such a big thing of it. And we've worked so hard over the years to build awareness, those of us in community mental health. And finally, we have reached a stage where, like Dr. Deshmukh just said, there's so much awareness that even patients ask us these questions. So have we done something wrong? Because now we are going over into type 2 and like from type 2 to type 1 and overdiagnosis and over-medicalization. So how do we drag this whole thing back, I think is a very interesting question. So wonderful. I really enjoyed listening to you, and all the references which you mentioned draw so much from sociology and, so many other disciplines. So thank you so much. Any questions from the audience? Yes.
My question is for Z codes. If prescribed antidepressants for Z codes or life issues, do they respond, the patients respond, and secondly, do they respond faster than psychosocial therapies?
I would argue that, psychosocial interventions are the treatment for Z codes. Basically, you're saying either there's a population public health problem of poverty or domestic violence at the home, both of which require psychological and social treatments. But if the person is not sleeping, maybe a low dose of amitriptyline will help. So in those, I often, nowadays, it's not a paternalistic doctor deciding what tablet you take. You talk to the patient and say, if you're not sleeping, I can give you something to help that will help you cope with your sleep and cope better the next day. But we need to look at your psychosocial circumstances and your personal circumstances to sort out this problem. So I kind of feel that we may not be able to sort out their problem. We have to empower them to sort their own problems out, but in case they're not sleeping, small doses may help.
Yes, ma'am.
It's not a question, but after hearing your presentation, sir, it reflects Ivan Illich book on medical nemesis, where he talks about the cultural heterogenesis, social heterogenesis. It's fantastic that I really enjoy your presentation, and I could relate. Now the DSM-5, how this overlapping of diagnosis and how it is entailing to the different stakeholders, its impact. Health industry and the pharmaceutical industry. It's beautiful, sir.
Yes.
I must tell you a story. When I was the chair of the IPS committee on DSM-5 before it was launched, and we had the subcommittee looking at DSM-5, and we critiqued it from an Indian perspective. And I was a bit anxious when we were to meet the American Psychiatric Association people to discuss DSM-5 in 2013-14. And I must admit I was anxious because I had actually written a strong critique of DSM-5. And in the opening statement, the president of the American Psychiatric Association said, he did not talk about evidence for DSM-5. He said, this is a document for the health and hospital industries in the US. If you are unhappy with it, please make your own.
Yeah.
He said if the American Psychiatric Association doesn't do it, Congress will authorize somebody else to do it. He never talked about that we have evidence for DSM-5 diagnosis, nothing. And as soon as I heard that, I thought there's really no debate. I don't have to argue my case.
Oh my God. Okay, last question from ma'am. Oh no, Parker ma'am also. So after her, maybe we'll. Okay, ma'am, go ahead.
Yes, I think it was beautiful lecture, Dr. Jacob. I now not in the urban, I am in the Adivasi community where I work at Palghar. What I was thinking when you talk about the overlap of depression and anxiety, there is a third thing which come in my mind, and that is a victim mindset. And this is something, probably it is not a diagnostic, but you are not even talking, you are talking about the range of it, and especially women. This is something which we really like to look at, this victim mindset. The symptoms or the expressions overlap, basically with the depression. So what do you think about it?
If you've listened to Satish Deshpande, who's a sociology professor in Delhi, his argument is for poor people, Adivasis and low caste, there is nothing going for them. India is a fully capitalistic society for rich people like us. And the only card they can play is either the gender, they can highlight their caste or their gender, because they have lost hope in the government in helping them through poverty. And that is why the demand for this caste status. Those of us who don't see our caste is because we don't need to see our caste, despite the fact that we have all had privileges and we don't acknowledge them. So that is the tragedy of their lives, and we shouldn't say that, they are playing victims. Even Donald Trump is playing victim all the time. So this is a way to attract attention, but these people have genuine problems.
Yeah, so actually, sir, just linking caste, gender, along with that, even age. Like ma'am said about Ivan Illich, he spoke of, yes, clinical, social, but also structural. And that is where today we see people are not, it's almost like a fascism, you're not allowed to age. But aging and death is a natural process. So, that whole shift that needs to come back to a social understanding, I think that was highlighted very beautifully in your talk. One last question there and then we'll stop.
Ma'am, it's not one, it's 3 points.
Okay,
If you may
up to
permit.
him to answer them, yes.
Yeah, no. So the first thing is, I have brought out a compilation of the ICD-11 codes, and I invite you all to see it, which is on display. And we now have the M and Q chapters in ICD-11, and you are allowed to diagnose all these things in that. The second point I want to make is not only psychiatry, but all medical disorders are ultimately a common final pathway for psychosocial stress. And now with climate change, also environmental stress. So I think it's not a value judgment to say that medical and psychiatric disorders are separate. We can have that discussion maybe over a coffee, but they are not separate. This is the thing that we operate on, and that's the problem that psychiatry has been suffering from. Because when all the reports are normal, it falls in the doorstep of a psychiatrist. That's what we see, I think in Bombay, most of us are consultation liaison psychiatrists. So I think that's not a value judgment, that I consider it as a reality. And the third point that you said, historically, if you have seen, the DSM-3 has come only for administrative purposes. There is no compulsion. And we accept that it's an empirical diagnosis. It's not a binding diagnosis. Now, the entire politics and the social thing that's come around saying that, okay, you have 4 criteria, minor, major, and that is why you give this. That is something you have to, in your training, you might be very, like you said, very anancastic about it, that I have 4 criteria, this is typical, this is atypical. But when you become a fully formed psychiatrist, all of us know that these are only guidelines. What we do on our practice is give relief, and for a very long time, it is the politics of the society that doesn't want to change, and whether it is obesity, whether it is hypertension, whether it is learning disability, it is ultimately the doctor's job to fix, and we should not fall for this hoax. That is what is my thought here. What would you say?
Yes, so I agree that the ICD-10 had it at the back, as now they have split it up in various chapters in ICD-11, but I think they're definitely worth looking at so that we can use them more often and we can confidently use them. This issue about physical disease, the fact that after 50 years, we haven't got a diagnostic test for any of our conditions. Any of our conditions means that it is not a structure, at least we don't have evidence. I'm not saying it's not a different, psychosis definitely is a brain problem, but it's at a molecular level, I agree. But we don't have that evidence to argue like fracture femur. We don't, to say it's a physical problem. So that's why I'm not saying that I believe that bipolar, schizophrenia, delusional disorder, these are all sort of psychosis, end of the spectrum. Definitely there's a brain problem. There's no, I'm convinced, but we don't have a diagnostic test for it. So then pushing the other extreme of distress to equate it with mental illness becomes slightly problematic.
Yeah. Well, thank you very much, Dr. Jacob. It was excellent. We can go on and on to a topic of that kind, but it's our pleasure. Thank you so much.
Thank you so much, Dr. Jacob. We are very grateful for your thought-provoking insights on medical distress, which will encourage us to approach psychiatric care with both scientific rigor and human sensitivity. I now request the chairpersons to please felicitate our speaker. I would now like to request Dr. Prashant Shah, sir, to please felicitate our chair. the Vice President of Bombay Psychiatric Society, to please felicitate our chairpersons.